Hello everyone, welcome to HIM 216. This will be a continuation of our lecture discussing Chapter 9 in your textbook. If you will, please turn to page 184. And we are going to be reviewing the guidelines for sepsis, severe sepsis, and septic shock in this lecture. Now, when we're coding sepsis, in the index, literally, we look up the term sepsis. And we can see that there is a code for generalized sepsis, for sepsis with an unspecified organism, and that code is A41.9. And we use this code when the physician tells us that the patient has sepsis, but there's not an organism identified that is causing that sepsis. We don't have to have an organism identified. Usually blood cultures are performed on patients who they think have sepsis. They'll do some serial blood cultures looking for an organism in the blood that could be causing this systemic infection. But if those blood cultures come back negative, and if the physician documents that the patient has sepsis and they are presenting with the symptomology of sepsis, we go ahead and we code it. And that code we use is A41.9. I can't tell you how many times I have used that code because the patient was documented as being septic, but we had no organism. Now, when we do have an organism, when we have positive blood cultures, and we do have a link, we need a link between the sepsis and the blood cultures. If we don't have one, then we generate a query. Then we do code to that specific organism. So for instance, E. coli, and that code A41.5, and then 0. Well, let's see. I picked A41.51, sepsis due to Escherichia coli. We do use that very specific code for the organism. And if we look at this category, A41, you will see that we do have some instructional notes, and these have to do with guidelines. Post-procedural sepsis, we'll specifically talk about that. And then, of course, we have our OB patients, and of course, codes from Chapter 15 related to pregnancy would be sequenced first. Then we have sepsis following an immunization or an infusion or transfusion. We have an excludes note 1, bacteremia NOS. So for instance, if this is neonatal sepsis, it is actually coded in the neonatal chapter, which is Chapter 16, conditions in the perinatal period. Streptococcal sepsis is actually coded to a different category. Then we have our excludes note 2, and this is sepsis due to RN, and these are all the different disease processes that patients can have and then also have sepsis. If let's go to Chapter 1. And if we look at this category list, we have streptococcal sepsis and then other sepsis. If we look at streptococcal sepsis, we do have some guidelines here. Code first, and of course we would have to follow those. We have an excludes note 1. This is very similar to what we saw in category A41. And then this is the different the sepsises that are due to different types of strep. And then when we look at A41, other sepsis, and very often this is where you will find your self looking for codes. So if a patient has sepsis due to MRSA, A41.01, and if we're over here, you can see that if we put in the organism, then we're going to find the code. And our codes for sepsis are from categories A40, A41, unless of course it's an OB or a newborn. Are also due to a postoperative or due to a device. Now, let me okay. Now, we also have guidelines that deal with severe sepsis. And when we're coding severe sepsis, and this is terminology that you will hear physicians use, severe sepsis and severe sepsis. Severe sepsis codes to category R65.2. It is in the category R65. Signs and symptoms associated with systemic inflammation and infection. You'll notice that this code is coming from Chapter 18, which right away you should say to yourself, oh, this can never be a principal diagnosis code. And you do have instructional notes that tell you have to code first an underlying infection. So for this category, you must first have for R65.2, you must have first the sepsis code. And of course you can see sepsis NOS A41.9. Now, severe sepsis is typically associated with organ dysfunction. An organ dysfunction, you can see some examples listed down here. Kidney failure, respiratory failure. I'm not going to read all those for you. But if the patient has an associated organ dysfunction, you also add these codes. So a patient who had severe sepsis with respiratory failure would have 3 codes. The first code would be for the sepsis, and I didn't say an organism, so that would be A41.9. The patient has severe sepsis without septic shock, so it would be R65.20. And then I would have a code for the acute respiratory failure, J96.00. So when we're coding sepsis, as long as we're just coding the sepsis, it's pretty straightforward. One code, you want to specify, you want to code the organism. However, if it is severe sepsis, you're going to have at least 2 codes, and if they have an organ dysfunction, you will have 3 codes. So now let's look on the top of page 184. And let's look at this first example. The patient presents with sepsis. The physician decides that the sepsis is secondary to Staph aureus found in blood cultures. The patient also has Staph aureus pneumonia. So I'm going to code the Staph aureus pneumonia A41.01. I'm going to look at my category, make sure I don't have any instructional notes here that I need to address. And then my patient also has Staph aureus pneumonia J15.211. Look at my instructional notes here. They are not applicable. So those are the 2 codes that I have for this patient. It doesn't say the patient has severe sepsis. We don't assume that the pneumonia is an organ dysfunction. So we just have those two codes. Now, I, on page 184, basically tells us that if we have negative or inconclusive blood cultures, that doesn't mean that we can't code sepsis in patients who have clinical evidence of the condition, but we should query the provider. So we're going to see, when we go look at sepsis, we're going to see what those criteria are. And there are times that the patients come in and clinically they are a picture of a patient that is septic. If the provider treats the patient as though they are septic, but he does not include that diagnosis, then certainly you can generate a query. So if we look at this example, the patient comes to the ER, they have shaking chills, they have a temp of 104, their white blood count's 14,000. The physician suspects that this patient is septic, so they do blood cultures. The blood cultures are negative for a bacteria, but the patient documents that the patient has sepsis. So we would be using that default sepsis code of A41.9. Now I want to talk to you about urosepsis. This is an old term. It is not uncommon for patients with urinary tract infection due to E. coli to become septic. Particularly in the elderly, it can be very difficult to diagnose that urinary tract infection, and by the time they figure out that the patient has a UTI, they have become septic. And so physicians used to have a diagnosis that they would use of urosepsis. Well, what you have to know with urosepsis, is it a urinary tract infection, or is it sepsis, or is it both? So if you have documentation of urosepsis, you can't code it. You have to know what they are talking about. What do they mean? And you will either be that maybe that they just have a UTI and the physician is calling it urosepsis, in which case you would only be coding of the urinary tract infection. It may be that they have a urinary tract infection and they are septic, and the physician doesn't know what the organism is. In that case, you would be coding sepsis, A41.9, and the code for the urinary tract infection. If they developed an organ dysfunction, such as acute kidney failure, then you would also be coding that acute organ dysfunction. And if they have sepsis, the sepsis will be the principal diagnosis code. In the third example on page 184, patient comes to the ER, fever, painful urination. Physician documents urosepsis and admits the patient for IV antibiotics. You're going to have to query the physician to get clarification on that terminology because we can't code urosepsis. In the fourth example, patient comes in the hospital with sepsis and acute renal failure secondary to sepsis. In this instance, we're coding the sepsis. We're using the default code A41.9. Then we're using the code for severe sepsis without septic shock, R65.20, and then the code for acute renal failure, which is N17.9. If a patient has an organ dysfunction that isn't clearly associated with the sepsis, or and the documentation in the record says that it's a condition other than sepsis that's causing that organ dysfunction, then you don't use a code for severe sepsis. The acute organ dysfunction has to be associated with the sepsis in order for us to assign that severe sepsis code. And if the documentation isn't clear, then you just have to query the provider. In the example that we have on the bottom of page 184, the patient comes in with sepsis, pneumonia, and acute respiratory failure. And in this instance, there's no documentation that indicates that that respiratory failure is due to the sepsis, so we can't code the severe sepsis. We're coding the sepsis with no organism, the A41.9. Then we're coding the fact that they have pneumonia, and then the fact that they have respiratory failure. And the respiratory failure could be due to the pneumonia. We don't know. But we do, of course, code the organ dysfunction, which is the respiratory failure. We just don't code the severe sepsis. And on top of page 185, it tells us that if we're coding severe sepsis, it takes at least 2 codes. One for the underlying systemic infection, and that is the sepsis. You look up sepsis to get that. And then you have a code from category R65.2 for severe sepsis. And if we don't know what the organism is, then we use A41.9. So we're at sepsis, and we don't know what the organism is, so we use the default code A41.9, sepsis unspecified organism. Then if the patient has severe sepsis, we're coding sepsis and then severe. And that code is R65.20. They don't have septic shock, and then if there is organ dysfunction, we're going to have a code for the organ dysfunction. Now, we have this code R65.21, severe sepsis with septic shock. Septic, and I'm on top of page 185. Septic shock refers to circulatory failure associated with the severe sepsis, so it is an organ dysfunction. When patients have septic shock, first you're going to have the code for the systemic infection, possibly A41.9 if you don't know what the organism is. And then you're going to have the code for the severe sepsis with septic shock, R65.21. Or you will have code T81.12. That is post-procedural septic shock. And if we go to sepsis post-procedural, we will find this code T81.4. If we do now, let's do shock. If we do shock post-procedural septic, we'll find the code T81.12. And when we look in this category, this is complications of procedures. We do have an excludes note 2 that we need to look at. These codes do have required 7th characters. And this code T81.12, basically, we have an instructional note, code first underlying infection. Use an additional code for any associated organ dysfunction. So post-procedural septic shock would be shock, a patient goes into shock after they have surgery. It's related specifically to the procedure. And of course, that has to be documented in the record. And the code for T81.12 cannot be a principal diagnosis code. And that you know that because it tells you here you have to code first the underlying infection. When we look at this example on 185, the patient was admitted with septic shock and acute renal failure caused by UTI due to E. coli. So this patient had a urinary tract infection due to E. coli that has caused the acute renal failure and the septic shock. And the discharge summary says sepsis due to E. coli. If we are coding that, we are going to sepsis Escherichia coli A41.51. That's our principal diagnosis code. We also have to code the urinary tract infection, and that's N39.0. Then we also have to code the fact that this patient has septic shock, R65.21, severe sepsis with septic shock. And then our organ dysfunction is acute renal failure. N17.9, and I put in failure renal acute. Failure renal acute, N17.9. And so those are the things that we pull out to code. Okay, on the bottom of page 185, let's talk about the sequencing of severe sepsis. So if severe sepsis is present on admission and it meets the definition of the principal diagnosis, then that underlying systemic infection would be assigned as the principal diagnosis. So remember, when we're coding severe sepsis, our principal diagnosis code has to be the code for the actual sepsis itself. A code from category A40 or A41. Then our second code, or a secondary diagnosis, is the severe sepsis, the actual R65 code for the severe sepsis. A patient can be admitted with severe sepsis. A patient can actually develop sepsis and severe sepsis after admission. And if you look at the example on the top of page 186, the patient comes in with pneumonia due to Staph aureus. Several days after admission, the patient develops septic shock due to the Staph aureus. So our principal diagnosis here, the condition determined to have occasioned the admission, is pneumonia, Staph aureus pneumonia, J15.211. And then after admission, the patient develops septic shock due to Staph aureus, and to code that septic shock, we have to code sepsis Staphylococcus aureus A41.01, and then this patient has the septic shock R65.21, and we add those two codes to the pneumonia. The septic shock wasn't present on admission. Now also on page 186, let's look at number 4. If the patient, the reason that the patient is being admitted is for sepsis or severe sepsis and a localized infection such as pneumonia or cellulitis. Pneumonia is a localized infection localized to the lung. An acute urinary tract infection would be localized to the urinary tract. Then the code for the underlying systemic infection should be assigned first. So the pneumonia would be assigned first, the cellulitis, the urinary tract infection. I'm sorry. The code for the underlying systemic infection should be assigned first, so that's the sepsis code. And then the localized infection should be assigned secondary. I don't know why they can't be more clear about that. So if a patient comes in and they have sepsis or severe sepsis and something like pneumonia, cellulitis, then the code for the sepsis is going to be sequenced first, then the code for the localized infection. And it could be a urinary tract infection, it could be pneumonia, it could be cellulitis. Sometimes patients with cellulitis go on to develop sepsis. If the patient has severe sepsis, then we're going to have a code from category R65.2. Now, if the patient's admitted with a localized infection and the sepsis doesn't develop until after admission, then the localized infection code is signed first, followed by the appropriate code for the sepsis or severe sepsis. And that is consistent with what we just looked at in number 3 on page 185 and 186. So basically you look at the condition that determines the occasions the admission of the patient to the hospital. If it's sepsis, sepsis is sequenced first. If it's another infectious process, that infectious process is sequenced first. So let's look at this second example on 186. The patient came in with acute respiratory failure due to Staph aureus pneumonia. The patient also has sepsis due to Staph aureus that's associated with the respiratory failure. So in this instance, the patient, the staph sepsis is present on admission. That code's A41.01. We also code the Staph aureus pneumonia, J15.211. We code the respiratory failure, which is J96.00. And then we have the code severe sepsis, R65.20, severe sepsis without septic shock. So this is the inversion of what we have in the first example on page 186, where a patient comes in with Staph aureus pneumonia and then days after admission they develop septic shock due to Staph aureus. So this is just inverted situations. In the second situation, the sepsis is present on admission, and so it's sequenced as a principal diagnosis. Now in number 5 on page 186, sepsis due to post-procedural infection. So there has to be documentation of a link between that post-procedural infection and the sepsis. You can't just assume that postoperatively, if a patient becomes septic, that it is a post-procedural infection. And we do have several codes that can address this. We have T80.20, and this is for an infection after a transfusion, an infusion, or an injection. And if we go to infection and then put in post, we'll see postoperative T81.4, postoperative wound, post-procedural. We also have here post-vaccinal T88.0. And if we look at these codes in the index, in the tabular, we see T81, that category is complications of procedures not elsewhere classified. We do have use an additional code here as well, and it excludes 2. And you can see that there are a number of post-procedural codes here. We're looking at T81.4, infection following a procedure, and of course you would want to read all of the instructional notes. There is an excludes note 2, infection due to prosthetic devices, implants, and grafts, infection due to infusion, transfusion, and therapeutic injection, T80.2. In the index, we do see infection port or reservoir, T80.212. And this is in the category complications following infusion, transfusion, and therapeutic injection. In the index, if we go to infection and then due to, we have a list of specific types of post-procedural infections due to a central venous catheter, due to infusion, injection, or transfusion, NEC. So, you know, there's triple lumen catheter. So this is also a note card type of thing for me to be able to help find these particular codes. Let's look on the bottom of page 186. So this patient came to the ER. She had an infection of her operative wound. She is septic due to an operative wound infection. So very clear documentation. 2 weeks ago she had an open appendectomy. That's fine, but we're not going to code anything related to that appendectomy. So she has literally a post-operative wound infection, T81.4. And you'll notice that if I tried to code this just from the index, I would not get the correct code. I have to go to the tabular, and these are set codes that are driven by a 7th character. So this is an initial encounter. So for this particular code, I would be choosing .4XXA for the initial encounter. Then she is septic. Do I know the organism? No, I do not. So I know that I am going to be using the default code for sepsis, A41.9. And then this Y code is an external cause code, and we will study those in more detail next semester. I want you to turn to page 193 in your textbook. This is the discussion of sepsis, and you can see the criteria for sepsis: hypothermia, tachycardia, tachypnea, hypocapnia. This is very important information to read. It breaks down the sequencing of coding for you. On page 194, exercise 9.2, I want you to answer questions 9, 11, and 13 for this lecture. Page 194, exercise 9.2, questions 9, 11, and 13. And then on page 187, sepsis and severe sepsis associated with a non-infectious process. We talked about these guidelines earlier in the tabular. This category is R65.1. We have to code first to the underlying condition. And then for 7 and 8, these have to do with sepsis of pregnancy and newborn, and they have their own guidelines and their own codes. So that's going to conclude the second lecture for chapter 9, and we'll have one more lecture which will be much shorter than these last 2 lectures, and that will wrap this chapter up for us. If you have any questions, let me know.